Now I will talk on femoral shaft fracture. Femur is the largest and strongest bone in the body. High energy traumas are most common cause for femur fracture in younger population, low energy trauma in elderly population. Associated fractures are femoral neck fractures in 2 to 6% of patients. You have to do an X-ray of the pelvis in all patients with a fractured neck femur. If there is clinical suspicion, you have to do CT scan or an MRI scan, and it is covered by very strong muscles, and these muscles act as a deforming force after fracture. There is a simple OTA classification is there. A means simple fractures, B wedge fractures, C complex fractures. But this classification won't make a big difference in the treatment of femoral shaft fractures. Coming to the investigations, you have to investigate the patient after stabilizing. X-ray of the thigh with the one joint below, one joint above is required. CT scan and MRI pelvis is required to rule out associated injuries. In suspected fractured neck femur, we can do both CT scan and MRI pelvis, but MRI pelvis is more sensitive in diagnosing fractured neck femur in a polytraumatized patients. You can do a rapid limited sequence. Coming to the treatment, non-operative treatment is very rarely done, but it is regular treatment for pediatric femur fractures. In adults, it is done only for unfit patients or bedridden patients. You can put a long leg cast or a hip spica in children. Adults, long leg cast or some traction if the patient is very serious or unfit or bedridden. In children, you can treat with the hip spica. Coming to the operative treatment, antegrade or retrograde intramedullary nailing is a standard of treatment nowadays. Antegrade is more popular. External fixation with a conversion to intramedullary nail within 2 to 3 weeks in case of unstable patients. Open reduction and internal fixation with a plate is another option. Antegrade nail is the standard technique for the fracture femur, but retrograde nailing can be done in ipsilateral femoral neck fractures, where you can fix femur from the below and a neck with the cancellous screws. Multiple system trauma patients, bilateral femur fracture patients, floating knee, morbidly obese patients where you have difficulty in entry point, ipsilateral acetabular fracture to minimize the soft tissue injury. These are some of the indications for retrograde intramedullary nail. Coming to the indications for plating, you can do a plating in case of ipsilateral neck fracture requiring a screw fixation for the neck, fracture at distal metaphyseal diaphyseal junction, inability to access the medullary canal because of the narrow canal in case of a deformed femur, pregnancy and pediatric patients. These are some of the indications for the plating. In pregnancy, some surgeons prefer doing a plating to avoid radiation. Intramedullary nailing of femoral shaft fractures in skeletally immature patients. There was a study in JPGS 2014. They did a nailing. Starting point was trochanteric entry point, and mean age was 12.9 years. And what they noticed was only 2.2% of patients had a asymptomatic coxa valga, no avian, and the conclusion of the study was trochanteric entry rigid intramedullary nailing of femoral shaft fractures in skeletally immature patients is an effective treatment with an acceptable rate of complications. Fracture table compared with a flat radiolucent table. Worldwide, fracture table is commonly used for the nailing and it is good for reduction, but you can do nailing without fracture table also. Reaming and femoral intramedullary nailing can be performed safely and effectively on a flat radiolucent table. Antegrade compared with a retrograde nailing. There was one study published in Journal of Orthopedic Trauma 2000. According to that study, results of retrograde nailing are currently comparable with those of antegrade nailing. Nailing with or without reaming. Effect on fracture union. Reaming is also thought to improve fracture healing by means of autogenous bone grafting through deposition of bone from the reaming at fracture site. Reamed nailing is better than unreamed nailing. Pulmonary effects of intramedullary nailing of the femur after reaming. Is the risk of pulmonary complication increased? There was one study in JBJ's 2001. According to that study, reaming is not an issue in trauma patients without chest injuries who have been well resuscitated. Intramedullary nailing after reaming does not seem to have a detrimental effect on patients with only a thoracic injury. It seems that extent of resuscitation rather than the presence or absence of thoracic injury is the critical risk factor for further pulmonary damage as a result of intramedullary nailing after reaming. Management of femoral fracture associated with head injury. There is no evidence in the literature that early fixation of the femoral fracture is deleterious in the presence of severe head injury. Aggressive resuscitation and invasive monitoring are required to achieve and maintain stable intracranial and systemic parameters. Secondary union of critical segmental femoral defect or a comminution or a large displaced fragment. Secondary union of segmental femoral defects may occur. The mechanism by which this occurs is poorly understood but is likely related to the biology of the fracture site, the effects of reaming and mechanism of fixation. There is no need to fix big fragments which are displaced during the nailing. If it goes for non-union, you can do a bone grafting later. Conclusions. Femur fractures are usually high energy trauma. Stabilize the patient, then do investigation. For suspected fractured neck femur, MRI is better than CT scan. You can do rapid limited sequence. Antegrade nailing is possible in adolescents with a trochanteric entry point with minimum complications. There is no need to fix bone fragments aggressively during nailing. And nailing can be done in chest and head injury patients after resuscitation and stabilizing is vital.